Have you ever paused to think about the incredible internal systems just quietly running the show inside your body?
Yeah.
These are your hidden command centers,
Yeah.
orchestrating everything from your energy levels to your mood swings, often without you even realizing it.
It's truly remarkable how precisely these systems operate, largely thanks to a tiny but uh, mighty network,
Yeah.
your endocrine glands.
That's right. And today we're taking a deep dive into some of the most impactful disorders of this amazing endocrine system.
Wow.
We've pulled together a stack of sources that really delve into the adrenal, thyroid, parathyroid, and, well, a few other key glands.
Okay.
We'll explore their crucial functions and, maybe more importantly, what happens when their delicate balance gets thrown off.
Right.
Our mission here is to kind of give you those aha moments, clarify the really important insights, and make you feel truly well-informed without all the usual information overload.
Think of it as maybe a shortcut to understanding the master regulators of your internal world.
Okay, let's unpack this incredible system and its surprising twists, starting with our body's stress responders, the adrenal glands.
The adrenal glands are absolutely crucial.
Yeah.
They sit right above your kidneys, and they're vital not just for managing stress, but for a whole host of other critical functions that, keep your body humming.
Right.
And when something goes wrong, the effects can be, well, pretty dramatic and far-reaching.
And one of the most fascinating disorders of the adrenals is called pheochromocytoma.
Mm-hmm.
This is essentially a rare tumor that develops in the adrenal gland itself. What's truly intriguing is that these tumors can overproduce powerful stress hormones like norepinephrine.
Exactly.
And the symptoms are so distinct, they even have a clever little mnemonic to help us remember them.
They do. It's the PHE mnemonic, standing for the three most common and striking symptoms: palpitations, headache, and episodic sweating, also known as diaphoresis. So imagine your body's internal alarm system constantly stuck on fight or flight.
Mm.
That's kind of the relentless, overwhelming state for someone with pheochromocytoma.
Wow.
It's a profound and intense internal surge that can be truly debilitating.
Understanding that constant internal surge is really key to grasping why managing this condition is so complex, isn't it?
Yeah.
What's the approach before surgery? Because you can't just jump right into removing a tumor that's like pumping out all these powerful hormones, can you?
Precisely. No, you can't. Medical management before surgical resection of the tumor is absolutely critical.
Okay.
The goal is to mitigate the effects of that excessive norepinephrine. So we're talking about medications that specifically block those powerful stress hormones drugs, like alpha and beta blockers.
Right.
Other general antihypertensives might also be used, along with anti-anxiety medications, all to sort of calm that overactive system down.
And I understand there's a particularly tricky moment during the surgery itself, right? A potential complication?
There is, yeah. A critical complication during the surgery is a sudden, really dangerous spike in blood pressure and heart rate as the tumor is manipulated.
Wow.
It can release just a flood of hormones all at once. That's why those preoperative medications, particularly alpha blockers like centolamine, are so crucial.
Okay.
They help prevent that potentially life-threatening surge.
So it's all about controlling that potential hormonal explosion. Makes sense. And what about after the surgery, especially if the entire adrenal gland had to be removed? An adrenalectomy, is that right?
Adrenalectomy, yes.
Ah.
If that's performed, significant amounts of hydrocortisone are given postoperatively.
Mm-hmm.
This is vital to support the body as it's suddenly without its natural hormone production from that gland.
Okay.
It's essentially replacing what the body is temporarily missing.
Now let's flip to the complete opposite side of adrenal issues. Adrenal insufficiency, more commonly known as Addison syndrome.
Right.
If pheochromocytoma is the body stuck in overdrive, what happens when these same stress response glands can't produce enough?
This is a state of hyposecretion. So, not enough of crucial adrenal hormones, both glucocorticoids and mineralocorticoids.
Okay, break those down a bit.
Sure. Glucocorticoids, like cortisol, manage things like blood sugar and the body's stress response. Mineralocorticoids, like aldosterone, control your body's salt and water balance, which is vital for blood pressure.
Got it. So what causes this critical shortage?
Well, it can stem from various factors, including the surgical removal of an adrenal gland, maybe decreased function of the pituitary gland, which normally signals the adrenals, or even long-term steroid therapy can suppress them. Other causes include the adrenal gland simply atrophying, or conditions like cancer, PB, HIV, and even autoimmune diseases where the body mistakenly attacks its own adrenal tissue.
So what does this actually feel like for someone experiencing it? You mentioned earlier, imagine craving salt constantly and even seeing changes in your skin tone.
That's a powerful way to visualize it, yeah.
What else goes wrong when these crucial hormones are in short supply?
The manifestations are indeed striking. Patients often experience profound weakness, chronic fatigue, nausea, vomiting.
Wow.
But what really stands out are those visible signs like hyperpigmentation, a darkening of the skin, almost like a permanent tan in some areas.
Interesting.
You'll also see low blood pressure, a rapid heart rate, and extreme fluctuations in body temperature. And there are imbalances in crucial electrolytes, things like low blood sugar, hypoglycemia, or abnormal sodium and potassium levels,
Which affects everything.
which affect everything, vital for nerve function, heart rhythm. That distinct craving for salty food is very characteristic, as are things like emotional ability, depression, and a diminished libido. It's a fundamental breakdown of the body's baseline regulatory system.
That's quite a range of effects from just a pair of tiny glands. It really highlights how interconnected our energy levels, mood, even our basic salt cravings are to just two types of hormones.
Absolutely.
Now let's pivot to another pair of masters in our body's orchestra, the thyroid and parathyroid glands, our metabolic maestros and calcium controllers.
Right. The thyroid gland, located in your neck, it secretes two primary hormones, thyroxine, or T4, and triiodothyronine, T3. These hormones are absolutely vital for regulating, well, virtually every aspect of your metabolism, from growth and development to how quickly your cells use energy and even the activity of your nervous system.
And it's all part of this incredibly elegant, sort of precise feedback loop, isn't it?
Exactly. It's a beautifully designed system. Your hypothalamus secretes TRH, which prompts the pituitary gland to secrete TSH.
Okay.
TSH, in turn, signals the thyroid to release T4 and T3. When T4 and T3 levels in the bloodstream are sufficient, they send a negative feedback signal back.
Telling them to ease off.
Exactly, telling the hypothalamus and pituitary to stop producing TRH and TSH. This maintains a perfect balance.
And the thyroid does one more thing, right? Calcitonin?
Yes, good point. It also produces calcitonin, which is responsible for decreasing calcium levels in the blood and promoting its storage in bones.
And then, tightly linked to the thyroid, you have the parathyroid glands. They're essentially calcitonin's counterpart in this calcium balancing act.
Yes, the parathyroid glands, usually 4 small glands nestled behind the thyroid, they secrete parathyroid hormone, or PTH. PTH is an antagonist to calcitonin. It works in opposition. It increases serum calcium levels by drawing calcium from bones, absorbing it from food, reabsorbing it in the kidneys.
So pulling it out of storage.
Precisely. And it also helps regulate serum phosphate levels. Together, calcitonin and PTH work in this delicate dance to keep calcium in your blood within a very tight, healthy range.
Which is critical.
Critical for nerve and muscle function, bone
Yeah.
strength. Yeah.
Okay, let's talk about when that goes wrong. Hyperthyroidism, often known as Graves' disease. This is where that finely tuned metabolic system goes into like rapid overdrive.
It's essentially an excessive secretion of thyroid hormones, T3 and T4. The exact cause is often unknown, but it's frequently linked to autoimmune factors. Or sometimes triggered by significant physical or emotional stress, pregnancy, or maybe an infection.
How is it typically diagnosed? What are they looking for in the blood work?
Diagnosis involves measuring hormone levels. You'll typically see elevated T4 and T3 levels, coupled with a decreased TSH.
Right, the feedback loop again.
Exactly. That low TSH is a critical clue because it shows the pituitary is trying to slow down the thyroid, but the thyroid is just ignoring the signal and keeps pumping out too much hormone.
This is where you see the body quite literally running too fast. What does that intense acceleration look like for someone experiencing it?
Well, imagine feeling constantly on edge. Patients often present with extreme nervousness, agitation, significant mood swings. They might be irritable, prone to emotional outbursts. Physical signs include tremors, constant jittering, and inability to remain motionless. A really striking symptom is significant weight loss despite a ravenous appetite.
Because their metabolism is just burning through everything.
Burning through calories like crazy.
Yeah.
Many develop a goiter, an enlarged thyroid gland, and exophthalmos, or bulging eyes.
Right, that's a classic sign.
It is, caused by fluid buildup behind the eyeballs. Other symptoms include a racing heart, tachycardia, high blood pressure, an intense intolerance to heat, frequent diarrhea, elevated body temperature, moist skin, and persistent insomnia. It's truly like their internal engine is just redlining.
That sounds incredibly draining and just disorienting.
It is.
What's the medical and nursing management to help someone grappling with Graves' disease?
Medical treatments focus on slowing down that hormone production or blocking its effects. This includes medications like thiamazole and propylfuracil, which block T3 and T4 synthesis.
Okay.
Beta blockers are crucial for managing the heart rate, anxiety, and tremors. Another common treatment is ablation therapy, using a therapeutic dose of radioactive iodine to essentially shrink or destroy the overactive thyroid tissue.
Right.
And if medical control proves difficult or ineffective, a subtotal thyroidectomy, surgical removal of part of the thyroid, might be performed.
And what about the nursing side? How do they help make the patient more comfortable and manage those symptoms?
Nurses focus on providing really supportive care, offering high-calorie foods, often with between-meal snacks, is essential to combat that rapid weight loss.
Makes sense.
And avoiding caffeine or other stimulants is key. Monitoring vital signs and daily weight is paramount. Because of their heat intolerance and increased sweating, keeping the patient's room cool and quiet and ensuring skin is clean and dry are also important interventions.
If surgery, a thyroidectomy, is on the table, what kind of pre-op teaching is critical for patients to understand? What do they need to know?
For a thyroidectomy, it's crucial to teach patients how to support their head and neck when changing positions after surgery, to minimize strain on the incision.
Okay.
Deep breathing exercises are generally encouraged, but coughing that might be restricted or require specific instructions from the doctor, as it could put stress on the suture line. Voice rest for about 48 hours is also vital, and nurses will regularly check the patient's voice for any excessive hoarseness, which could indicate nerve irritation.
And post-op care seems incredibly important, given the, delicate area of the surgery.
Absolutely. Critical. The patient should be kept in a semi-Fowler's position, head slightly elevated, with neck hyperextension carefully avoided.
Right.
And as a critical precaution, suction equipment and a tracheostomy tray must always be kept at the bedside, just in case of airway swelling or obstruction.
Wow. Okay. Serious stuff.
Very serious. A cool mist humidifier can help prevent coughing and irritation. Nurses constantly monitor vital signs, respiratory rate, depth. Before any liquids are given, swallowing ability is assessed, and then the patient's diet is gradually advanced to soft foods.
What are the absolute critical things to watch out for after a thyroidectomy, the big risks?
There are a couple of major concerns. First, bleeding is a primary risk. Signs include an increased pulse, decreased blood pressure, a feeling of fullness or pressure in the neck, or unexplained restlessness. The dressing must be checked frequently.
Not just the front, right?
Not just the front.
Yeah.
Check the sides and back of the neck, even on top of the patient's shoulders, as blood can pool there due to gravity. Coughing, as we mentioned, can sometimes strain sutures and cause bleeding.
And then there are two other very serious complications. One is tetany. That sounds intense.
Tetany is a crucial complication. It can occur if, inadvertently, the parathyroid glands are removed or damaged during surgery.
Ah, because they're right there.
They're tiny and right behind the thyroid. This leads to dangerously low blood calcium levels. Remember how vital calcium is for nerves and muscles?
Yeah.
When it's low, the body's neurological system goes haywire. The classic signs are numbness and tingling, especially in the toes, fingertips, and around the mouth, what we call circumoral paresthesia. You might also see carpopedal muscle spasms, where the hands and feet cramp up, or even laryngospasm and stridor, a high-pitched breathing sound indicating airway constriction.
Scary.
Very. These are dramatic neurological alarms, especially the positive Schwalsteck and Trousseau signs, which are specific reflex tests.
Oh.
Emergency treatment involves all the administration of calcium gluconate.
Immediately,
because without it, convulsions and severe cardiac dysrhythmias can occur.
Wow. Okay, and the other major concern is a thyroid storm or crisis. That sounds like an emergency, too.
It is a medical emergency where all the signs and symptoms of hyperthyroidism are severely exaggerated.
just amplified.
Massively amplified. We're talking about extremely high blood pressure, a dangerously rapid heart rate, intense sweating, diaphoresis, and severe hyperthermia, high fever.
What causes that?
It's typically caused by manipulation of the thyroid during its removal, releasing a huge surge of hormones, and usually erupts within the first 12 hours post-op. This can rapidly lead to severe outcomes like cardiac dysrhythmias, heart failure, even delirium. Medical management involves immediate and aggressive interventions. 4V fluids, potassium or sodium iodide, Corticosteroids, antipyretics, oxygen, it's all hands on deck.
Right. Now, let's explore the opposite end of the spectrum, hypothyroidism, which can manifest as myxedema or cretinism. Here, it's like the body's natural pace has been dialed way, way down.
Exactly. This condition involves suboptimal thyroid hormone levels, leading to a drastically decreased metabolic rate.
Okay.
It can stem from a problem with the thyroid gland itself, it's just not producing enough, or maybe a deficient pituitary gland secretion of TSH, meaning the signal isn't reaching the thyroid adequately.
And there are two distinct forms depending on age.
Right. Myxedema is severe hypothyroidism in adults. It's characterized by a sluggish metabolic rate, profound lethargy, apathy, generalized swelling due to fluid retention, often called non-pitting edema. Patients often experience intense cold intolerance and significant weight gain. Cretinism, on the other hand, is severe hypothyroidism present from infancy.
Oh, wow.
Without enough thyroxine early on, it causes significant mental retardation and defective physical development. Crucially, it's partially reversible if treated immediately after birth.
But maybe not fully.
But the mental deficiency may persist even if physical and sexual development normalize later. It really highlights the profound impact of thyroid hormones on early brain development.
So, when the body's pace is truly slowed, what are the shared symptoms across both forms? What does that look like?
For both myxedema and cretinism, common manifestations reflect that drastically slowed metabolism. Patients experience a profound intolerance to cold, often feeling chilled even in warm environments,
Right.
along with weight gain and chronic constipation. They may have deficient speech and hearing, a significant slowing of thought processes. Adults might experience decreased libido, increased reproductive difficulties.
Okay.
Their skin often becomes thickened and dry. They might develop a sort of mask-like facial expression, with hair thinning and falling out. There's also exercise intolerance, general weakness, decreased blood pressure, and respiratory rate.
Sounds like everything just slows down.
Everything slows. Other symptoms include pervasive fatigue, brittle hair and nails, a deepened hoarse voice, joint pain, depression, elevated cholesterol levels, anemia, and menstrual disturbances. It truly affects almost every system.
How is this critical shortage of hormones managed, especially with medications? Is it lifelong?
Generally, yes. Management primarily involves lifelong hormone replacement therapy. The cornerstone medication is levothyroxine, often known by brand names like Synthroid. This is typically taken once a day, every day at the same time, usually before breakfast, because food can interfere with its absorption.
Okay, key point.
Very key. And it's important to monitor for side effects. If symptoms of hyperthyroidism begin to appear like racing heart, anxiety, weight loss, it suggests the dose may be too high and the patient's metabolism is being pushed too fast.
Finding that balance again.
Exactly.
And what about general care for someone with hypothyroidism? What helps them cope day to day?
Nursing interventions focus on supporting that slowed metabolism. Providing a warm environment is crucial due to the cold intolerance.
Right.
A low-calorie, low-cholesterol, low-fat diet, along with increased fiber, is recommended to manage weight gain and prevent constipation. Daily weights and encouraging ample rest periods are also important.
And a caution with other meds?
Yes, absolutely. It's crucial to monitor for increased side effects from sedatives, hypnotics, and anesthetics, as hypothyroid patients metabolize these much more slowly and are far more sensitive to them.
Good to know. Okay, next we have simple goiter, that visible enlargement of the thyroid gland. What causes that specifically?
This enlargement, often with some swelling or edema, is most commonly due to insufficient dietary iodine.
Ah, iodine.
Yeah. If the thyroid doesn't have enough iodine, it simply cannot produce enough T3 and T4. To compensate, it tries to work harder, and as it does, the tissue grows, leading to that visible enlargement.
And what are the symptoms of this enlargement? Just the swelling?
Manifestations primarily relate to the enlarged gland pressing on surrounding structures in the neck. So that can cause dysphagia, or difficulty swallowing,
Okay.
dyspnea, which is difficulty breathing, and sometimes hoarseness if it presses on the vocal cord nerves.
How is it typically managed? More iodine.
Medical management can involve potassium iodine supplements, often given with fruit juice to mask the taste, or simply increasing iodine-rich foods in the diet, like iodized salt.
Right.
Thyroid replacement therapy might also be prescribed to kind of tell the thyroid it doesn't need to work so hard, or in some cases, a thyroidectomy if the goiter is particularly large, causing compression symptoms, or cosmetically bothersome.
What's the nursing focus here besides the potential surgery risks?
The focus is on monitoring the patient's airway, especially if the goiter is large and teaching. And importantly, if a thyroidectomy is performed, nurses are vigilant in watching for those three major post-op complications we already discussed: bleeding, tetany, and thyroid storm. Educating patients on ways to aesthetically hide a small goiter with scarves or high collars can also be helpful for self-esteem.
Let's briefly touch on thyroid cancer, which sometimes presents as a nodular threat. How common is this?
Most thyroid malignancies are papillary adenocarcinomas. These are thankfully relatively rare, usually non-metastasizing, meaning they don't spread easily, and often curable with a thyroidectomy. The prognosis is generally very good.
That's encouraging. How is it typically discovered or diagnosed?
It's often diagnosed when a patient or doctor discovers a painless, palpable nodule in the neck during an exam.
Oh, okay.
A thyroid scan will then often reveal what's called a cold nodule. This means it shows a decreased uptake of radioactive iodine compared to the surrounding tissue, a sign it's not functioning normally like healthy thyroid tissue, which raises suspicion for cancer.
And the treatment approach is usually surgery.
Medical management typically involves a total thyroidectomy, removing the entire thyroid gland, or, in cases where it might have spread to nearby lymph nodes, a radical neck dissection. Patients will then require lifelong thyroid hormone replacement therapy, since their thyroid is gone, and potentially radiation or chemotherapy, depending on the specifics of the cancer staging.
And nursing is, again, about watching for those post-op issues.
Exactly. Nursing interventions reinforce watching for those three major thyroidectomy complications and encouraging meticulous follow-up care to monitor the hormone replacement therapy and check for any potential recurrence.
Now let's shift our focus back to the parathyroid glands and their unique set of disorders. First up, hyperparathyroidism, where there's too much PTH, leading to too much calcium in the blood.
Right. This is a hypersecretion of parathormone, or PTH. Remember, PTH pulls calcium out of the bones and puts it into the blood. So too much PTH causes a profound loss of calcium from the bones, leading to hypercalcemia, excessive calcium in the blood, and usually hypophosphatemia, low phosphate levels.
And the manifestations for this one are quite memorable, aren't they? There's that little saying.
Indeed. It's often summarized with a rhyme: bones, stones, groans, and psychic moans.
Okay, break that down.
Bones refers to osteoporosis and pathological fractures, as calcium is leached from the skeleton, making bones brittle and weak.
Right.
Stones signifies kidney stones, formed because the kidneys are trying to filter out all that excess calcium.
Makes sense.
Groans points to gastrointestinal issues like nausea, vomiting, constipation, and abdominal pain. And psychic moans describes the neurological and psychological effects.
Like what?
Things like muscle weakness, fatigue, joint pain, depression, and sometimes changes in mental state or confusion. Patients may also experience cardiac dysrhythmias, hypertension, excessive urination, polyuria, and excessive thirst, polydipsia, because the body's trying to flush out the calcium.
What's the management strategy for this overactive calcium system? Do they remove the glands?
Sometimes, yes.
Wow.
Medical management can involve a parathyroidectomy to surgically remove one or more of the overactive glands. Medications can also be used. Furosemide, a loop diuretic, is given to increase calcium excretion through the kidneys. Calcimimetics are a newer class of drugs that essentially trick the parathyroid glands into thinking there's enough calcium, thereby decreasing PTH secretion.
Interesting.
And calcitonin itself can also be used therapeutically to decrease skeletal calcium release and promote its excretion.
What about nursing interventions for someone with hyperparathyroidism? What are the priorities?
Restoring fluid and electrolyte balance is crucial. Patients are encouraged to drink a lot of fluids, minimum 2,000 milliliters of oral fluids per day, and IV therapy may be needed to help flush the calcium.
Right.
Accurate intake and output monitoring is essential, and all urine should be strained to check for kidney stones.
Okay. Diet.
A low-calcium diet, so avoiding milk or dairy products, is recommended. Cranberry juice can sometimes help promote acidic urine to discourage stone formation.
And safe.
Fracture prevention is key due to those fragile bones, so safety measures are important. Patients should also be taught not to take antacids containing calcium. Mild weight-bearing exercise is actually encouraged as it helps keep calcium in the bones.
Okay. And post-op if they have surgery?
Post-parathyroidectomy, nurses are vigilant for the opposite problem: signs of hypocalcemia tetany, since PTH levels might drop suddenly. Also watching for cardiac dysrhythmias, carpal tunnel spasms, and checking urine for blood, hematuria.
And finally, for the parathyroid glands, hypoparathyroidism where there's not enough PTH, leading to not enough calcium in the blood.
Exactly.
Yeah.
This is a hyposecretion of parathormone. And as we mentioned, it often occurs because of the inadvertent removal or destruction of one or more parathyroid glands during a thyroidectomy.
Making it a complication we need to watch for.
Absolutely. It's a critical post-op complication to monitor after neck surgery.
And the symptoms, of course, sound very much like the tetany we talked about earlier with thyroidectomy complications.
That's absolutely right, because the underlying cause is the same, low calcium. The resulting hypocalcemia causes that range of neurological and muscular issues.
So the tingling again.
Yes. Patients experience paresthesia, that unsettling numbness and tingling in their extremities and around the mouth, along with muscle spasms, cramps, and full-blown tetany. You'll definitely see those positive Schwastek and Trousseau signs again.
Which show that nerve irritability.
Exactly, indicating low calcium. In severe cases, tetany can escalate to critical issues such as bronchospasm, difficulty swallowing, dysphagia, cardiac dysrhythmias, seizures, and potentially a life-threatening laryngeal spasm, cutting off the airway.
It's a clear signal that the body's fundamental electrical and muscular functions are compromised. What's the immediate medical response when someone goes into hypocalcemic tetany?
Medical management includes immediate IV administration of calcium gluconate or calcium chloride, given at a slow, controlled rate to carefully raise blood calcium levels without overshooting.
And long-term?
For long-term management, vitamin D is given, often in an activated form, because it's essential for increasing the absorption of calcium from the gut and helping raise its levels in the blood.
And how do nurses help manage this condition, besides watching for the tetany itself?
Nursing interventions include implementing seizure precautions, as severe hypocalcemia can trigger seizures.
Right.
It's also important to carefully watch for signs of hypercalcemia. If giving IV calcium gluconate, things like a slowed heart rate, nausea, vomiting, abdominal pain, or disorientation as too much calcium can also be dangerous. Finding that balance again.
Always the balance. And diet.
For diet, a high calcium, low phosphorus diet is recommended. This includes foods like dark green vegetables, dairy products if tolerated, soybeans often supplemented with calcium and vitamin D.
We've covered a lot of ground with the adrenals, thyroid, and parathyroid, which are arguably the heaviest hitters in this endocrine orchestra.
They definitely have widespread effects, yeah.
But the body has many other crucial players, each conducting their own unique solo. Let's take a quick glance at a few more of these fascinating glands before we wrap up.
Indeed. Good idea. First, the female sex glands, the ovaries. They produce estrogen, which is responsible for developing female secondary sex characteristics.
Right.
And progesterone, which prepares the uterus for conception and helps maintain pregnancy, working with the placenta. These hormones are fundamental to reproduction and female health overall.
And the male sex glands. The testes.
The testes, the male sex glands, primarily release testosterone. This hormone is crucial for the development of male secondary sex characteristics, deeper voice, muscle mass, etc., and of course, for sperm formation. It's central to male reproductive and physical health.
What about the thymus gland? Many people don't even think of it as an endocrine gland, maybe more immune system.
Well, it bridges both. The thymus gland, located in the chest behind the sternum, produces thymosin. What's fascinating about the thymosin is that it stimulates the development and maturation of T lymphocytes, or T cells.
Okay.
And these T cells are absolutely vital for cellular immunity, playing a crucial role in your body's defense system against pathogens, viruses, and even abnormal cells like cancer.
So really important. And finally, the pineal gland, often shrouded in a bit of mystery deep in the brain.
The pineal gland, yes, a tiny gland deep in the brain. It secretes melatonin.
Ah, the sleep hormone.
Melatonin is well known for its role in regulating our sleep-wake cycle, helping us maintain those circadian rhythms. But it also seems to play an important, though maybe less understood, role in preventing premature sexual maturation in children.
Interesting.
Kind of acting as a brake on puberty until the appropriate age.
Wow. We've truly explored the incredible control these tiny glands exert over such vast bodily functions. I mean, from metabolism and growth to mood and immunity. It's truly mind-boggling how these microscopic chemical messengers can wield such colossal power over our entire being.
It really highlights just how intricately connected these internal systems are, doesn't it? If we connect this to the bigger picture, you can really see just how delicate and yet how robust our internal chemistry truly is.
Yeah.
A small imbalance in one of these command centers can indeed lead to widespread, sometimes dramatic effects throughout the entire body.
It's truly fascinating to consider how much precise machinery is running inside us at all times, constantly working, adjusting, trying to keep us balanced. Perhaps the deepest